Good afternoon, everyone. My name is Eoin Summers and I work as a public health doctor in the Department of Public Health East in Dr. Stephen's Hospital here in Dublin. Thank you very much for giving me the opportunity to speak at today's conference. The title of my talk is Migrants and the Exacerbation of Existing Inequities Associated with the Emergence of a Monkeypox Outbreak in Ireland. I'm here today to discuss with you what myself and my colleagues learned as we attempted to manage this new outbreak and why it's relevant to the themes of today's conference. On the 23rd of July, Tedros Adhanom Ghebreyesus, the Director General of the WHO, declared the ongoing outbreak of monkeypox across the world as a public health emergency. This followed on from reported sporadic cases across many European countries, initially with the first case reported in the United Kingdom in May 2022 of a male with reported travel links to Nigeria where the disease is endemic, followed by further cases with no epidemiological links to an endemic region. As per the external WHO Situation Report 7, from the 1st of January through to the 18th of September this year, 61,753 laboratory confirmed cases of monkeypox and 23 deaths have been reported to the WHO from 105 countries. To date, Ireland has 194 cases reported to the HPSC, with 192 identifying as male and 2 as female. Of these, 19 have been hospitalised with no deaths reported, thankfully. So what is monkeypox? Monkeypox was first discovered in 1958 when 2 outbreaks occurred in colonies of monkeys that looked like pox disease in a Danish laboratory. However, monkeys are not the source of infection, as rodents such as squirrels and Gambian pouch rats have the largest reservoirs of the virus. Monkeypox virus is a zoonotic orthopox DNA virus, which means it is spread from animals to humans and related to the virus that causes smallpox, and was first described in humans in 1970 in the Democratic Republic of Congo, formerly known as Zaire, where it was diagnosed in a 9-month-old child who had not been vaccinated against smallpox. It has since become endemic in Western and Central Africa. The clinical presentation varies, but can begin with fever and flu-like symptoms. This is often followed by a vesicular rash similar to that of chickenpox, generally seen on the face, palms of the hands, soles of the feet, and occasionally in the mouth. Following sexual contact, the rash can also be found in the genitals and around the anus and may not spread elsewhere. Scabs then form, which eventually fall off. The picture on the lower right of the screen shows a 4-year-old female in Bondua, Liberia, with classic monkeypox lesions. Who has monkeypox affected? Well, the epidemiological pattern that has emerged of these cases bears a striking resemblance to the early cases of HIV/AIDS in the 1980s. A study in New England Journal of Medicine by Thornton et al., looking at 528 cases from across 16 countries during the initial outbreak, found that 98% of cases were gay or bisexual men who have sex with men, with 43% living with HIV infection. This percentage of gay or bisexual men has remained largely static throughout the outbreak. The suspected means of monkeypox virus transmission, as reported by the clinician, was sexual close contact in 95% of the persons. Unlike the HIV/AIDS epidemic, we know the etiological agent in this case and have had an effective vaccine for some time, along with antiviral treatments, but unfortunately the repeated warnings from endemic countries in West Africa to deal with the issue at the source has fallen on deaf ears. Given how little we know about the epidemiological characteristics of the current outbreak, it's prudent to heed an observation made during the first year of the HIV/AIDS pandemic that any assumption that it will remain restricted to a particular segment of our society is truly an assumption without a scientific basis. Thus, additional detailed epidemiologic and observation, cohort studies, serosurveys, and ongoing surveillance for new cases are of critical importance. So what is then the public health response? As with all new outbreaks and threats to public health, a swift yet often imperfect response is needed early. This is best summed up by the WHO head of emergencies, Mike Ryan, who said, "Be fast, have no regrets. If you need to be right before you move, you will never win." Once notified of a clinically probable or laboratory confirmed case, an initial public health response is to ensure the index case has somewhere to isolate. With monkeypox, this period of isolation is prolonged, often up to 21 days from initial symptom onset. On the top left of the screen, you can see St. Ita's in Portrane, the old psychiatric hospital, which has been retrofitted to become the new national isolation facility. Once isolated, contact tracing would then take place to track all contacts who the index case may have encountered during their infectious window, the beginning of which was the onset of symptoms or 24 hours prior to the rash appearing. Those of greatest interest to public health teams were sexual contacts, who were expected to be at the highest risk of transmission, followed by household contacts sharing facilities with the index case. Management of these contacts included getting them to monitor themselves for symptoms of monkeypox for 21 days from last contact with the index case, which is the incubation window, and to offer them vaccination. The vaccine used was actually a smallpox vaccine, which comes from the same family of viruses, which has been shown to be effective at reducing transmission if given within 4 days of contact with the index case, and reducing severity of symptoms if given between 4 and 14 after contact. This vaccine was used off-label, but has been approved by the European Medicines Agency, and was something that has been used and tested before for use with smallpox. We set up a community vaccination team which operated through an adaptable hybrid model whereby the vaccination team had the flexibility to be mobile, enabling them to go out to close contacts' homes where there may be 6 or 7 contacts in one house requiring vaccination. This allowed greater access for those who may not have been able to come to the vaccination centre in West Dublin, and ensured vaccination could be done quicker to prevent transmission. So in terms of our own Department of Public Health East data, from the 26th of May to the 30th of August, the North Dublin Public Health team were notified of 54 monkeypox cases with 93 associated contacts. We have the highest caseload both regionally and nationally. 57% of cases were migrants, the majority from South America, all identified as gay, bisexual, or men who have sex with men. Many cases lived in crowded or temporary accommodation where they had difficulty isolating, with 15% of migrants requiring isolation facilities. The mean number of household contacts per case was significantly higher in migrants at 2.1 compared with 1.1 for Irish nationals, increasing potential for viral transmission and demand for vaccination. Since those dates, we have an additional 30 cases to our department, bringing our rate of migrant cases up to 60%. We've had an additional 4 cases who needed isolation, bringing the total up to 9. And to date, no national case has required isolation at the National Isolation Facility. We also had our first female case through heterosexual transmission, which meant reassessing the case definition to widen the testing net. So how does monkeypox disproportionately affect migrants? Well, as with a new emerging disease outbreak, the fault lines of society appear. Migrants face a number of additional challenges, which were highlighted throughout our work on managing this outbreak. Migrants tended to live in more cramped, crowded accommodation, often sharing bedrooms at extortionate rent with strangers, and as a result, had significantly higher number of close contacts, potentially increasing the potential for monkeypox to spread, and the number of individuals requiring both monitoring and vaccination. This often led them to require government isolation facilities, which can be a lonely and unpleasant experience. Prior to the opening of the new national isolation in Portrane, prior facilities were often described as inadequate and unkempt by cases. An additional burden was the challenge of combating stigma, where, like the HIV/AIDS epidemic of the 1980s, being diagnosed with monkeypox often led to the perceived stigma that they brought this on themselves by engaging in risky behaviours. Additionally, the combination of being from a foreign country and identifying as GBMSM led to an intersection of perceived racism and homophobia. Cases who lived in shared accommodation with strangers often feared disclosing diagnosis to contacts for fear of retribution or persecution, or fear of being evicted, due to following up with the contacts of cases whereby contacts are either aware of the case's diagnosis or that they have an isolation requirement. These contacts may discern a case's likely or actual sexuality, given that the information in the public domain states that nearly all cases are men who identify as GBMSM. Language barriers challenge cases in advocating for themselves, whether trying to access follow-up care or social welfare supports. Migrants disproportionately suffered financially, with many working in low-paid employment on temporary contracts, and due to the necessity of having to isolate for approximately 3 weeks, the loss of income and the unavailability of government assistance to cover left them out of pocket, concerned about eviction and loss of employment. Finally, it would be remiss of me not to mention how we have arrived at our current position in the context of today's talk, and to take this opportunity to put out a call to arms. The current outbreak has emerged out of a Central African endemic zone in West Africa, where an outbreak has gurgled away since 2017 with little urgency response and WHO engagement around vaccines in those countries. The mortality and case fatality rates are far higher in endemic zones of West Africa, and despite multiple warnings and flares sent up to address the issue by those regions, the response has been limited. Like the COVID pandemic, an unpleasant scramble for effective vaccines and treatments takes place, where once again we leave our brothers and sisters on the African continent behind. We must do more to put pressure on the pharmaceutical companies to relinquish vaccine patents and allow mass production of vaccines at cost price to ensure those who suffer most have equity of access. Thank you very much.